is minimal residual disease, or maybe better term is measurable residual disease. So it is disease that we can measure at a very low level. For example, if we think about MRD at level 10 to minus 6, it means more or less that 1 of a million cell is detected, 1 malignant cell out of 1 million healthy cells. Of course, it is a little bit simplification because we have methods that use, for example, flow cytometry or next generation sequencing, and we need to assess limit of detection, limit of quantification. So it is not literally 1 out of million, but to have just idea what is MRD, I think it is good to know that is disease of very low level. During this EHA meeting, Professor Jamroziak will summarize our, Polish Myeloma Consortium study on MRD-directed therapy for multiple myeloma. In fact, PREDADOR studies, there were 2 studies. The first study was PREDADOR-BP, which is biochemical relapse. So we treated patients earlier once they have a protein level that exceed normal value, but still is not of diagnostic for active multiple myeloma, and typically we do not initiate treatment so early, and these results are ready for publish. We proved not only that such a strategy prolongs event-free survival, progression-free survival, but overall survival. So earlier treatment means better efficacy. Here we summarize MRD-driven approach, where patients who are after transplant, because we need effective treatment that eradicates disease to minimal level. So we have patients after treatment that are MRD negative, and we analyze intervention, which was daratumumab monotherapy versus observation. At this point, we can prove that such approach prolongs event-free survival and reduces the risk of event for more than 80%. Of course, we still need more mature data, including overall survival, but this initial data, I think, are in line with our previous observation that earlier treatment brings patients some benefit, and also the risk and toxicity is limited because we use only daratumumab as monotherapies. It is not double, triple, or even quadruplet therapy. So it is very well tolerated, but still efficacy is very good. We think that in future that means that we can individualize treatment. So patients who are at good response, so that patients are MRD negative, once we initiate treatment, they still are in the MRD negative status and require no therapy. So I think that's the future, that we first of all treat patients till they are on MRD negativity level, and we could start therapy earlier, so preemptive therapy based on MRD or MRD-driven therapy. Unfortunately, it is too early to say that we could change the clinical practice, but I think that is one of the directions for future treatments, that we could individualize treatment based on MRD.